We are educating you about therapy, not engaging in psychotherapy. There is a difference.
Love that line. Okay. Ready for the first one? How do you know if pain is part of the process or a sign that it's not working?
Okay, that's a great question. So how do you know if pain is part of the process or a sign that therapy is not working? So first of all, yeah, pain is part of the process. Like, we have to know that, right? When we're talking about painful things in psychotherapy, it's going to feel painful. It's not going to be it's not going to be comfortable. And one of the hallmarks for me of psychological health is comfort with discomfort, right? Being comfortable, being uncomfortable tells me, oh, you're healthy now. When a patient tells me, like, that's okay, I can be a little uncomfortable, I'm like, okay, we're sort of like getting to the end of our psychotherapy journey here, right? So yes, definitely comfort with discomfort. That being said, pain and suffering are not the same thing, right? Pain is pain. It hurts to grow. It hurts to change. It hurts to explore old thoughts, right? Suffering, when we're needlessly circling the same thing, when we feel like, okay, we're done with this, let's move on to something else, sometimes that's a sign that maybe we're over-focusing on something. The therapist is getting stuck perhaps on one aspect of the story and not letting us move on. And then the thing is, like I keep saying, then there's nothing you shouldn't be able to say to your therapist. Either she will have an answer or she won't, right? If she has an answer, then she has an answer. And, and she has a good answer, then fine, great, right? And if she doesn't, or she says, you know what, let me think that over, perhaps I am pushing too hard, or perhaps we are done with this topic, let's talk about it next time, and let me think it over, let me talk to a supervisor, let me talk to an advisor, great. Then that's fantastic. But the key here is, if you are not comfortable asking your therapist that question, then that's a problem. Right? Over asking your therapist that question might be wasting a little bit of time. If you're going to ask it and ask it and ask it, at some point you do have to trust, right? But asking the question, that's part of therapy. That's what therapy is.
Right. Okay. Amazing. By the way, is there anything that should be a red flag that's like, oh, this kind of pain is not okay in therapy?
I mean, certainly the kind of pain where you're being exploited in some way, right? There are stories where therapists, engage in inappropriate relationships with their patients. It almost never happens, but that type of thing, yes, that's obviously not okay. I think here or there, if a therapist has like prurient curiosity about a story and wants to know it more from the sake of like, ooh, I have the inside scoop of this famous story, you sometimes get that feeling, right? Like you're a little bit in a fishbowl, particularly if you're a high-profile person, or if your story's a high-profile story, or if your therapist doesn't have a ton of experience with what you're going through. So then the thing is, are you asking out of curiosity's sake? Like recently somebody reached out to me after this last live, and she was telling me some therapy experiences she had and why she didn't like them, and I asked her for the name of one of the therapists that she didn't like, and she was a little taken aback, and she wanted to know, like, what do you need to know? And I said, I'm only asking because I need to know the style of therapist that doesn't work for you, right? And sure enough, when she told me the three names, they were three therapists who have a very similar style. So now in my head, it's like, okay, I need a therapist who has an opposite style to these three people. Like, I wasn't asking out of prurient curiosity. I don't need gossip about other therapists. All three of them happen to be wonderful therapists. That style that they have, I guessed that was what was going on, but that style that they all three share doesn't work for her. Now that I know that, the first person actually that sprung to mind for her issue is a fourth person who is exactly like the other three in terms of style. So it's a good thing I asked, because now I referred her to like the opposite end of the spectrum. So yeah, but if you feel like, again, it's always like, so just like we say as therapists when a patient asks a question, so why do you ask? So you ask your therapist, so why do you ask, right? And they'll tell you if they have a good reason.
Right. Okay. Excellent. So somebody wrote this. She said, I've seen a number of times where people are in bad therapy, and she puts bad therapy in quotes.
Okay.
She says, but they don't know it. What concerns me is seeing therapists who create a feeling of dependency.
Okay.
Where the client is given a message that the therapist is the savior, they cannot function without him or her. Often I see this occurring with male therapist, right. Female patient, or the reverse. Or the therapist who causes a rift in the spousal relationship by aligning closely with one spouse, painting the other as the bad guy, and becomes the only support in this client's life. So not always are people aware or get the feeling that something is wrong when therapy has gone terribly wrong.
Okay.
I wanted to say something before
right.
I answer this, and that is, she is watching this from the sideline, meaning say at least the way
right.
the question is written. And
right.
I don't know if this question is about your personal experience, then far be it from me to say this. But if this question is about you observing another person in therapy, and what it looks like is they are cutting off their family members. They seem to be that the only person in their life who makes sense is their therapist, and maybe even quoting their therapist a lot in
right.
decisions that you may not appreciate or think is smart or anything in that nature. And there's a very easy way that a lot of times people say, well, come on. I mean, it's got to be that there's something wrong here with the therapy. I want to caution this and say it's very important, for sure, for people to be on the lookout if something's going wrong. But you do have to realize that the only perspective you're getting is that of a third party who's not in the therapy room.
Right. And you may not know, there may be a whole piece of this story, a whole chapter. You might know chapter 1 and you might know chapter 7, and you don't know the other chapters in between. There may be a whole piece of this story that you've never heard about. I'm sure we've all heard stories where like a couple gets divorced and people say things like he was the best person in the world, and little do they know that there's a whole backstory there that they never heard about, right? So this is a very sticky question, because are there therapists who are somewhat ill-intentioned sometimes? I'm sure there are, right? I sit on the state ethics committee. I listen to, stories all the time. Mostly though, most therapists who are licensed, right, and who have the checks and balances of supervision and being in their own therapy and right, and like they really are doing those things, are very aware of that potential. Because first of all, there is an organic purpose in the beginning stages of therapy specifically, sometimes to fostering that dependence a little bit. Sometimes when someone's been misunderstood their whole life, and for the first time someone gets it, yeah, that's almost an addictive feeling. And that's not a bad thing. In the short run, that's great, because that's the first time that person is hearing it, like they're willing to listen, right? And that willingness to listen, that willingness to change is so huge, right? That sometimes in the very, very short run, I like that. That's a good thing. That's not necessarily indicative of bad therapy. That's indicative of a person who's ready to hear and ready to change. So in the short run, yeah, being dependent on a therapist is not a bad thing. Feeling like this therapist is the only person who understands me, well, this therapist might be the only person who ever heard your whole story. So yeah, she's the first person who understands you. That being said, there are certain red flags that I don't like, and I say this for a lot of situations. First of all, whenever we make recommendations about other people in your life, especially when they're very drastic recommendations, my personal stance is don't make a recommendation like that without having met that person. Meaning, I learned this from when I did my, one of my postdocs was with Dr. Chaim Horowitz, who's a great, couples and family therapist. And he just keeps saying, I don't understand someone telling someone to get divorced without ever having met the spouse. Like, that just doesn't make sense to him.
I also want to pause this for 1 second and say, rarely, and again, obviously there are exceptions, but rarely do we find a therapist who's licensed and well supervised telling
anyone to do anything. Right. Telling anyone to do anything, right?
Telling them to cut off with this family member or anything of that. Right. Rarely is that ever done. It is in the exploration of therapy that can happen where a client comes to the realization that this is a toxic or abusive relationship. That can happen. But for a therapist to be directive and say, I want you to, do X, Y, Z is usually, unless there's incredible danger involved where their life is at stake.
Right.
I have yet to see a good licensed supervised clinician do that.
Right, exactly. I think the only times I've been that directive with people was when I really felt there was imminent danger of some sort, right? Meaning like somebody is, drinking and driving, right? Something like, okay, you cannot let your child in the car with that person until you find out what's going on, right? Where it's like very clear that like something's dangerous, right? Usually it's more like I'm noticing that every time you are around this person, you come into therapy the next time and you seem so different and you seem to regress. Let's think about that. Let's talk about that. And maybe the person comes to the realization that they want to instill some boundaries, maybe not. I feel this way also, by the way, when people give recommendations for what someone's child's school should do. Because without talking to the school, you don't really know the whole picture. So sometimes, I'm a school consultant. Sometimes I'll hear a mother will come into the school and she'll say, my therapist heard what's going on with my third grader, and she said that the school should totally do X, Y, Z. if your therapist is treating you,
if you work in a school,
right,
get some release, because half the time what the parent is telling you, if it's going against everything, if the parent comes in and says, my therapist said the principal and the teachers in this situation are awful,
right,
before you judge the fact that the therapist said that, try to have a conversation.
Right, exactly. And that goes both ways, right? Before I'm going to believe, or before I'm going to like act on the therapist said that I'm totally right, my daughter's class should be changed, I do want to talk to that therapist. But or the other way around, if you're the therapist and you're treating the mother, you probably shouldn't be making directive statements about what the school should be doing, right? Talk to the school if you think something's going on wrong, or suggest that the child see her own therapist who can deal with that. Which brings us to a topic, I know it's not the next question, but a few people messaged me about this idea of dual relationships, of not understanding them. Like, why can't my therapist tell me how to handle my anxious child? Or why can't my therapist treat me and my sister, right? Like, why is that a problem, right? Now, remember we had said last week, so Rivkah had a great example of this idea, this analogy that therapy is like a plumber, right? Where you hire a plumber, you say, please fix the drip that's over my dining room. And you really want to know why the plumber suddenly goes into the bathroom if the drip is in the dining room, right? And if the plumber can explain to you, you think you have a drip in the dining room, but the water main's behind the bathroom sink, okay, that makes sense. And if the plumber is like, I don't know, I just want to like go wherever I want to go, that's a red flag, right? So when we're talking about a dual relationship, your therapist is your agent. It's her job to represent your best interests. Your best interests and someone else's best interests might not entirely align. For example, I try not to treat, let's say, two kids in the same class. Because let's say I have two patients. I'm going to give a stupid example, but let's say I have two patients, and it would be in both of their best interests to be the main part of the school play. This girl would get a lot of confidence from it, and that girl would, finally, deal with her feelings of inferiority and having been bullied for whatever reason. It's in both of their best interests. Who do I advocate for, right? Let's say there's only one part, right? And like, there's no creative way to handle it. I can only represent the best interests of one person. If I'm treating you and your sister, your best interests might not both be aligned, right? In the same way, your therapist and you can have a conversation about your son's anxiety and how it affects you and how that might trigger your own anxiety and how you feel about it. But your therapist cannot treat you and your son, because the therapist can only represent the best interests of one person. And while 90% of the time you and your son's interests align, they don't always align exactly at the same time, at the same week, right? So it doesn't work. Now, if you're doing family therapy and I'm treating a family, I'm treating the mom, the dad, and all the kids, then yes, when we do family therapy, some things are amenable. They're meant for family therapy, and then we can treat the system. But then the family is the client. The mother's not the client, the father's not the client, the kids are not the client, the family is the client. So that becomes super important, right? Who is the client? Again, goes back to all of that ethics of like, what happens? Whose interests can I represent? Right? It might be in the child's best interest for me to be hard on his mother and say, no matter what you're going through, you can't do X, Y, Z. And it might be in the mother's best interest for me to say, I get it. Sometimes mothers, freak out, and sometimes mothers mess up, and be kinder to yourself, right? I can't give both of those messages at the exact same time to the two people if I'm representing each of them separately. I can only do that, like I said, if we're in family therapy, which sometimes family therapy is the best thing to do, but they are different contracts for different problems. So that's just important for people to understand.
Okay, so that was a very important piece, and it will cover
right.
questions. I come into therapy, my therapist never seems to have an agenda. It's up to me to choose the topics and stuff. I asked my therapist if she could pick, and she said she will never tell me what to talk about, and that it's up to me, and that I can choose to talk about whatever I want. Why does all the work on me, especially if I'm paying her?
Okay, so that is either excellent therapy or problematic therapy, because the therapist may be very mindfully telling this person, you need to take ownership of you, and you need to take ownership of your stuff, and you need to set the agenda, and you need to figure out what you want to talk about, right? And if that's the case, then the therapist is being absolutely appropriate. And yeah, it's true, you're paying the therapist, but it's your job to do the work. It's kind of like saying, I don't understand, I hired a personal trainer, why am I working so hard? You hired a personal trainer to make you work so hard. She cannot do the sit-ups for you, because if she does the sit-ups for you, she's going to get skinny, or her stomach is going to get strong, and you won't, right? The whole purpose of hiring her was to help you help yourself, right? That's what therapy is, right? So yeah, that's the job. That being said, when it becomes problematic it goes back to what the therapy contract was. And you should have a therapy contract with your therapist. Whether it's a written one or whether it's a talked about one, there should be a contract. Expectations should be set. So if your therapy contract with your therapist is, for example, very directive cognitive behavioral therapy about your panic attacks, right? Then yeah, your therapist should be the one setting the agenda. You should not be setting the agenda. Same with OCD. If you're coming in for exposure and response prevention for OCD, your therapist should be the one saying, okay, do you think we're ready to move to the next level? Are you ready to be exposed to this? Would you rather work on your fear of germs or your fear of choking while swallowing? That we can say, but we're not going to be like, let's just schmooze about your life. You contract with me for exposure and response prevention. Now, if a patient comes in and we contracted for like exposure and response prevention, we contracted for EMDR for PTSD, and she has a pressing problem on her head, and she says to me, I don't want to do EMDR today. I want to discuss this pressing problem. I'm going to ask a couple of questions, right? And one of two things is going to happen. Either I'm going to say, hey, you're being avoidant, right? You want to do anything but do what you came into therapy for. I totally get that, because nobody wants to go through their trauma sometimes. Like sometimes that's not fun, but I'm not going to let you do that. And sometimes I'll say, you know what? That pressing problem sounds important. This is a human interaction. We're going to break our contract a little bit with your full understanding that that's what we're doing and talk about this other issue. The idea, though, is informed consent, right? You know what the contract is and you know what's happening. So if your therapist is saying to you, no, I'm not going to pick the agenda for you. This is your job. You need to decide what you want to focus on. She is probably doing the exact right thing, or you picked the wrong kind of therapy for the kind of problem you have. Right? And either way, that's a conversation to have with her. Like, ask your therapist, hey, why am I doing the work? Hopefully she'll have a good answer for you. Right?
Right. Excellent. Okay. My therapist believes in talking. That's all we do. Talking about the past. People are telling me that CBT would be better. Learning how to cope despite the issues. I've mentioned this to my therapist. She doesn't seem to be comfortable with CBT and says that for me, it's just so important to talk. And that talking allows one to feel the emotions and helps one heal. Should I switch therapists like others recommend? I don't think she's certified in CBT or rapid eye movement types of therapy, which is basically EMDR.
Right.
Okay, I want to just say one thing for a second. Why are other people recommending what's going on in your therapy room?
Okay.
And that just jumped out at me in the sense of, I think every person needs to take ownership of whatever their therapy experience is or isn't, right? If it might have been your best friend may have had an amazing experience. I just had this tonight in a conversation with somebody. She said to me, I can't believe this therapist did such a bad job when she was so amazing for my friend. And I said, right, and she may not have been the right person for you and whatever your situation was.
Right.
We discussed this a little bit last week. However, I'm a little bit, it's jumping to me is that people are telling me, it seems like there are multiple voices in this therapy.
Yeah, there's a lot of people
that are having too much input into how the therapy is going down. And I'm wondering how much ownership this client is taking of the therapy experience.
Right. So here's the thing. First of all, we do a lot of talking in therapy. Whatever kind of therapy we do a lot of talking. There's very little not talking time in therapy. Sometimes it's processing time and sitting with something, but mostly in cognitive behavioral therapy, we do an awful lot of talking, right? We're talking about your thinking errors and we're exposing you to like what you don't want to think about and different ways of thinking about them and different coping tools all the time. It sounds like you are in some sort of psychodynamic psychotherapy, more of a processing-based psychotherapy. And again, it goes back to the contract. If you want a more skills-based approach, then yeah, this therapist might not be the right person for you, or this therapist might be exactly what you need, because what you need to do is talk through what you're going through. Another option you have, by the way, is, and I've done this here and there, I sometimes do contract with people to do psychodynamic psychotherapy. I know I talk a lot about being a CBT therapist, but I went to NYU. My background is in psychodynamic psychotherapy. It's the way I conceptualize. So I do a certain amount of psychodynamic and internal family systems work, right? Sometimes what I'll do with a patient like that, if I feel like she also needs skills, I might also send her to a DBT skills group at the same time, or individual DBT skills, right? So in that situation, what I'm doing is I'm doing therapy. We're processing, we're figuring out her story, we're helping her understand her patterns, we're talking through her life and helping her understand things, because CBT isn't the right approach for this patient. There isn't a clearly defined problem. And then at the same time, she's also learning skills in DBT. So both of those are being addressed at the same time, right? Because sometimes you do need both. So that might be an option, and that might be something that you want to think about. I don't love everyone is telling me. It sounds like there's a lot of everyone's telling you things. You know, it's kind of like when people, you know, post on their Instagram, like a picture of their kid having a meltdown, and they ask everyone to vote what they should do about it. Like, don't ask everyone to tell you. Pick a person who is the person that you discuss your therapy experience with, take advice from that person, and that's it. The wisdom of the crowd is not wise in this kind of situation.
Okay, I want to also add one thing, and this is just a pet peeve of mine, and Dr. K, you'll tell me if you agree. Whoever you're going to ask should have been someone who was successfully in therapy for a significant amount of time.
100%.
I often find that people who are advising other people in therapy have never actually been to therapy and don't know what that experience is like.
Right.
Therefore, what they're sometimes saying is like, well, no therapist should do that because I once read an article that said blah, blah, blah.
Right.
If you haven't been in therapy and haven't had the rupture repair, the ability to confront your therapist, the whole 9 yards,
right.
You may not have the insight that that person needs. And if you are that friend, tell your friend that you have never been to therapy, and therefore it's just not something you know much about, right?
Right. I don't know
twins,
this. Right.
I have twins. People who haven't tried to have certain things that are twin related are going to have a hard time giving me insight because you can't hear it too single, right?
Right.
Okay. Talking in therapy brings up the past, thoughts and feelings that I'm uncomfortable with. Then I come home in a bad mood, and I'm in a bad mood for the rest of the day. Is that normal?
Yes. It's normal and it's not normal. So here's the thing. You need a transition ritual out of therapy, right? We said, right, that therapy is about getting comfortable being uncomfortable, right? Of course, the goal is eventually being comfortable, like period, right? The goal is to process it and deal with it and get through it. If you're leaving therapy in a bad mood, one of two things. Either discuss with your therapist transitioning out 10 minutes before the session ends, you know, doing something to like bring your mood up. Or I personally, when I do therapy, which I always say therapy is the best gift you'll ever dread, right? I dread my therapy. I love my therapy. I have very mixed feelings about my therapy. It's great therapy, but I dread it because sometimes it can be painful and uncomfortable, which is what it's meant to be. I always have a cleansing ritual on my way home from therapy. I do not go from therapy straight to my regular day. I for sure don't go from therapy straight to patients because I think that would be wrong. So what I do is my therapy day is also a day that I do school consultations, but I build into my time, and it makes my therapy much more valuable. I build into my day time to do a cleansing ritual, to do something fun, to do something that sort of brings me into a different mind state, because I can't go straight from therapy, and especially if something's gonna be uncomfortable that's brought up, and straight to like, you know, giving a workshop in a school, because I will crash and burn later because emotions that you don't process end up processing you, and that's not a good feeling, right? So I do something. I have a transition ritual, and it could be like, you know, it could be stopping for coffee. It could be whatever it is. It's something that sort of brings up your mood. I like doing something a little visual spatial that brings up my mood and like lets me say, okay, now I'm ready to like rejoin my life, right? It could be like going to, you know, a store nearby and like window shopping, right? The idea is something, whatever you do, that makes you feel like you're ready to go back into your regular life again. Right?
Okay, amazing. I've heard that it's really important for therapists to be professional, including sticking to appointment times. My therapist always seems to go 5 to 10 minutes overtime. Is that okay? I feel like it's because she cares. Like if we have a breakthrough 10 minutes before the end, so she goes 10 minutes overtime to discuss it. I think that's nice. I repeated this to someone, and they were not impressed at all and said that's unprofessional and that a good therapist would have tied things up to end in time.
Totally. First of all, totally depends on the therapist. I will definitely, if I have to, go overtime with someone if I feel like we just got to a breakthrough, because why would I waste that opportunity? My goal, right, is to represent that person's interests, right? And if that person's interest is represented by me giving her a 52-minute hour instead of a 45-minute hour, that's a gift that I'm giving her. Now, I think it's worse when a therapist is late. I here and there will start a session a minute or two late because something like comes up or whatever, but I will always say to my patient, we're starting 3 minutes late. We're going to end 3 minutes late at least, right? Because I want to make sure they get there full time. I never want someone to feel that way. Personally, for me, for the way my brain processes information, if something very pressing came up, let's say I got a phone call from a psychiatrist I've been trying to reach for a while for one of my patients, and it's like 5 minutes before the session starts, and then I need to quickly jot something down, and therefore that person's session is going to be delayed even by 2 minutes. I like to acknowledge it, but I will delay that session by 2 minutes because I'd rather write it down than have it on my mind and not have all of my focus on the patient in front of me. So for me, for the way my brain processes information, I know if I brain dump it, even if I just send myself a voice note, spoke to Dr. Whatever, he said XYZ, therefore XYZ, great, I brain dumped it, now I can focus on the person at hand. I'd rather do that than try to say, okay, her appointment time is 12:30 sharp and it's 12:31. I'd rather brain dump that piece of information. It rarely happens, mostly because I am lucky enough to be, able to schedule my patients far enough apart that usually that doesn't happen. But when it happens, I think we should acknowledge it. Some people habitually engage in doorknob therapy. They talk about something totally not all that urgent, and then 10 minutes before the end of session, and this has literally happened to me. So I just found out I've been diagnosed with terminal cancer. It's like, oh, you were going to bring that up when? These kinds of things that happens. And it's like, yeah, I'm going to acknowledge that. We are going to talk about it. I'm not going to let you leave after dropping a bombshell like that. But that's me making the mindful choice that I'm going to give you a little extra time because we have to deal with that. And sometimes I make the mindful choice that this is too big, even if it is a bombshell. Sometimes I make the mindful choice that this is way too big, and if I try to address it now, it's not going to go well. I'm going to end up I'll feel rushed, and I'm not going to process it well with the person. I'll hurt them worse. So I don't do that. Sometimes I say, that sounds urgent, but we have to end now because this is too big to talk about. So let's make sure to start with that next time. I've made that conscious decision too. Again, the goal is always to make the conscious decision on behalf of the patient, for the patient, that the patient should be the most taken care of. So again, that person who's giving that opinion, oh my gosh, it's not professional for your therapist to give you 5 extra minutes. Your therapist just gave you a gift of 5 extra minutes, and with her clinical judgment and her clinical knowledge, thought that those 5 extra minutes were crucial for you. I don't think it's respectful of that person. Again, I don't know who that person is. If that person really knows you well, knows the therapist well, knows the situation well, has been in therapy herself, maybe not. But generally, I would say let's not second guess the therapist for something that's a very minor issue. It's not like my therapist touches me, I'm uncomfortable with that. Is that a red flag? It's not something that's very black and white. Your therapist giving you 5 extra minutes, I think it is not something someone else should opine about because they don't know what's going on.
I also want to bring up the fact that people may not realize there's something called the therapy hour, which has shrunk over the years. So within the concept, though, of therapy, originally most therapy was an hour. Right. And it has gone down, and for good clinical reasons, to about the 45-minute mark. But meaning to say, if somebody goes from 45 to 50 or from the 50 to 55, they're still within range of what's still considered the therapy hour. Right. If somebody were to tell me, by the way, and this I have seen, and I will tell you, and it usually happens with inexperienced therapists, and it used to happen to me a lot when I did intake with families, is that I gave it, let's say, 40 minutes or whatever it was, and I would literally go over time by about 25 minutes. That's a significant chunk of time. Right. And it tends to happen with people in the beginning because they're not sure about when they can move on. Right, yeah. That, if somebody's doing that and they're not an intern in a clinic, that's a red flag.
That is a red flag. That level of overtime is definitely a red flag, right? But that's whatever.
Or also, I'm just curious, though, if somebody consistently does doorknob therapy, causing the therapist to go 5 to 10 minutes late, because it makes them feel good that the therapist is giving them that extra 5 to 10 minutes. Right. How do you feel about that? That was the only thing that stood out for me. I was like, on one hand, I could see it working really well because maybe this therapist is about building trust and consistency with the client. On the other hand, are you totally blinded? Are you bringing it up?
In DBT, we have this rule that we're supposed to tell our patients what will burn us out. right? Because again, if you really want to trust me, you need to trust that I'm not going to just suddenly abandon you out of the clear blue sky, right? You want to know, right, what my thing is, what my rule is. So it's my job, even though I don't do DBT with everybody, it's my job to tell that to a patient. So I would bring it up. If that happens like 10 times in a row, I might say, I notice that you bring up these hot button things 5 seconds before the session is over. That's interesting. Let's talk about that. And then I want to figure out, is it because you only warm up and start to trust me 45 minutes into the session? Okay, then we have to think about that. And then maybe it's an exposure sort of to get you to like trust me 30 minutes into the session, right? Like maybe we have to talk about it, right? Or is it like, is there some sort of, like, I need you to think I'm more special than everyone else. I need you to care about me more. I need you to give me something extra. Maybe I need to feel like I'm getting a deal, whatever it is, right? There's all sorts of dynamic things, right, that people have. Then that's a conversation, right? Does it mean I don't care about you if we keep the session to 45 minutes? And then maybe we'll talk about the fact that you pay me. So does that mean I don't care you, right? Like all of those things then become huge clinical issues that we have to talk about, right? So it's something that a therapist should address. And sometimes in her clinical judgment, she says, I'm not going to address it right now because she knows what's going on and she's okay with it for whatever reason, but she's making the mindful choice that she's okay with it. But certainly what you don't want to happen, because a few people DM'd me about very painful experiences of like what felt like therapeutic abandonment. Your needs are too big for me. That's it. I'm not working with you anymore. Like just straightforward without giving them like a hint weeks in advance, I'm starting to get burnt out, or let's make up a rule so that this doesn't happen in the future, right? All of a sudden, like, boom, I can't see you anymore. That kind of thing won't happen if the therapist is open with the patient and like, let's talk about what's happening here. Why are we doing this, right? Why is this important? What's happening? And then great, that's the whole rupture and repair. That's part of a good therapeutic relationship, right? Therapists can't be afraid to bring things up to their patients either sometimes, right? And this is a beginning therapist kind of conversation that we have all the time in supervision, but okay.
Right. Okay. Ready for a big one?
Yeah.
What do you think about clinics?
What do I think about clinics? Can I pass?
Can I go first for 1 second? I got myself into huge trouble with a number of clinics a few years ago because I wrote some letter to the editor. So I want to clarify a few things that I've learned. And I have to say that I've been humbled to learn because I used to be a real anti-clinic person. Okay. What I've learned is that when somebody needs real managed care, a psychiatrist under the same roof with a therapist, with possibly other groups going on and stuff of that sort, means a multi-pronged approach.
Right, a case management approach, right.
Clinics, first of all, excel at that far more because they have the ability in the secretarial help.
Right, they have the ability to do the case management, 100%.
That's number one. Number two is at links because we deal with people who've lost a parent. Sometimes a parent will have 7 or 8 children that may have been in the back seat of that van when it crashed and their father died, and all 7 of them may need a form of therapy. Right. First of all, they'd have to mortgage their home if they were putting 7 kids in therapy at once.
For sure.
Secondly, they also sometimes need somebody, some supervisor who is seeing, wait a second, kid 1 is mentioning this in therapy, kid 3 and kid 7 and 8 and 9, and I'm beginning to be concerned that there's a pattern in this family, which may not have come up on its own if each of these children were being seen, say, by individual therapists in some form. So in both those cases, I will say that I've learned that I actually prefer to refer to a clinic in those cases. For sure.
I think in any case where you feel like it's like you're trying to empty the ocean with a tea dropper, like a teaspoon, right? You can't. Then in those cases, that's what clinics excel at. What you have to know about clinics, let's put it this way, my wish for clinics is that they had more expert supervision and that the supervisors were better trained at really creating a sense of clinical excellence amongst their staff. I feel like in supervision and clinics, sometimes the supervision groups are huge. The supervisor is supervising way too many kids, and the supervisor herself. Sometimes clinics don't do a great job of matching supervisor with supervisee, in the sense that, a supervisor who's supervising an OCD case should be someone who has done a ton of OCD treatment herself, not just went to trainings, but like what a clinic really should have, ideally in a perfect world, would be there would be an OCD supervisor who is an OCD specialist who does nothing but OCD all day, and a PTSD supervisor who's a PTSD specialist. And rather than having a supervisor, like I am Sarah and I'm being supervised by Diana, right? And that's what I do. And Diana just supervises all my cases. Really, it should be Sarah should be like, okay, I have a 9-year-old OCD. I'm going to this person for supervision. I have a 7-year-old with PTSD and a 15-year-old PTSD. I'm going to that person for supervision. And there should be that type of supervision where it's very content specific. That's a piece that I feel like clinics actually could do. They could bring in more experts to do ongoing supervision, not like day-long trainings, but ongoing supervision of specific types of cases. It would bring their clinic's ability up to like the next level. In a clinic, it's like this. The way it works sometimes is sometimes you get what you pay for. So when you need very expert treatment, when you need very specialized treatment, you're not going to always get that in a clinic, right? If you need like exposure and response prevention for OCD, you're not going to get someone with 15 years of experience doing that in a clinic usually. Sometimes you might, but usually you're not going to, right? You might get that, by the way, if you want to get that low cost, you might get that in a university medical center that has a training clinic for that, right? Like there are training clinics for like trichotillomania, and all the interns there who are psych students usually are learning how to treat trichotillomania, and then you're getting expert supervision and very targeted therapy. You can get that there, right? But in a community-based clinic, you might not get that. So it depends what the stakes are. It depends what you're looking for. Sometimes you're looking for supportive psychotherapy. Clinics are great at that. Sometimes you're looking for very targeted and specific treatment. What I think is important, though, is what people should know is if you've been in therapy in a clinic and you say, oh, therapy doesn't work for me, or this approach to therapy doesn't work for me, you have to think a little bit that perhaps it's not therapy that doesn't work for you. It's therapy with someone very inexperienced. You need the next level of care. Like that, you're not going. Just the same way that you wouldn't like get glasses for your kid based on your pediatrician's eye chart. You'd go to an eye doctor. Sometimes you need a specialist and your situation. I've also had a few times a situation, and again, I'm not saying the clinic did a bad thing. What I'm saying is that this person needs to know this. I've had people come into me and say like, oh, I did EMDR at this clinic, or I did CBT at this clinic, and it doesn't work for me. And I've learned before I accept that to say, well, let's go over the foundational principles of this. I once had someone come in and say, CBT doesn't work for me. I tried CBT, and her issue was very amenable for CBT. So I said, well, okay, let's go over some foundational principles. And I drew that standard CBT triangle, and she's like, what's that? I said, what do you mean, what's that? You've been in CBT? And she's like, what is this? And I was like, well, I'm sure you learned thoughts. And she's like, I never saw this before. Then, sweetheart, you didn't do CBT. Whatever the person who treated you told you were doing, it was not CBT. So before you say, like, this approach doesn't work for me because I tried it at a clinic, you might have tried it at a clinic with an intern who didn't really fully know it, and maybe 5 years from now she wouldn't do things that way. And so don't like discount that approach. Or like I tried EMDR, but the person like literally was doing eye movements with that patient the first session. Somebody very well trained in EMDR is not doing eye movements with you the first session, right? First, they're going to get your trauma loss history. First, they're going to establish safety. There's a million steps before you're doing eye movements. So again, EMDR did not work for you. Inexpertly done EMDR didn't work for you. So just take that with a grain of salt. Like, and if you're a beginning therapist, I see I have a few beginning therapists here on my live. If you're a beginning therapist and someone says that to you, or if you're in, starting at a private practice, first explore that a little bit before you take it at face value.
Excellent point. I think, by the way, some of this can be translated in general. Like if you went to a therapist and you feel this methodology or this thing doesn't work, just realize it may or may not have been the way it was worked through with you.
Right.
I think I just would add one more piece in terms of clinic work. I just want to say is that having visited various clinics by now, I've learned that not all clinics are created the same.
100%.
That's very important. Some of them, let's say, are more staffed with interns and beginners. Some of them do have some experience. Those are usually very hard to get into.
Right.
They're giving their pro bono hours or their hours that they're willing to take $34.20 for,
right.
Sometimes at a clinic and stuff of that sort. But it also, you have to realize something else. In a lot of the states, and this is something people don't realize, the reforms that have come about have created havoc in terms that clinics sometimes have their hands tied behind their back. They are forced in New York in certain in certain types of clinics to give 30-minute sessions and
right.
to do most of the supervision is on paperwork.
Right.
That's nobody's fault. The clinician can be fabulous. They cannot operate in a 30-minute session. Is hugging your therapist ever okay?
Hugging me is never okay. I have strong feelings about like physical contact. Like that's just, to me, that's a red line. That's a boundary. I think for every therapist that's different. I certainly think having the conversation about why you might or might not want to hug your therapist is a hugely useful like therapeutic tool. You know, and it's something that's a conversation to have. I'm not that comfortable with touch in today's, more because of risk management in today's litigious society. I just feel like that's an easy to hold red line. Like we're just not going to do that. There are cultures and places and types of psychotherapy that are more touchy-feely, where people do hug. There are like some group therapy works where everyone holds hands as they talk. There are situations where that is appropriate and it's not a red flag. Nowadays, if I would be supervising a beginning therapist, I would opt away from touch, right? I'm not very into touch. I mean, I'm not going to say I'm not entirely into touch in the sense that like I've definitely done play therapy with a little kid where like she wanted to pretend she's being my manicurist and giving me a manicure or something. And I was okay with that, right? Because like there was an organic reason for that play or whatever. Or if we're playing a game, I'm not going to like jump away 7 miles if my hand accidentally touches my patient's hand as we're like playing chess or something, right? Like things like that could happen. But I think that if your therapist wanted to give you a hug and you were uncomfortable with that and your therapist gave you a hug anyway, I would definitely be concerned about that, right? Like, but having the conversation about why I want my therapist to hug me, or I've had patients say to me, like, I fantasize sitting in your lap, or I fantasize that you're hugging me. I fantasize I'm a baby and you're rocking me in a rocking chair. You know, that's part of therapy. That's normal. Like that kind of like, you know, fantasy about it. A fantasy is not a reality. It's just a fantasy, right? And it says something about the relationship. It says something about how you feel. It's very valuable. But I think we go with our gut with things like that.
Okay. My high school daughter, this one you're going to get me, my pet peeve going. My high school daughter has lots of panic attacks lately. She was always intense, but it's really going bad. The school suggested that she see the school social worker, but I'm really wondering if school therapy is effective or if I should be sending her to a therapist outside of school. Can you explain a little bit more about when yes or when not to use school therapy?
So this is a great question.
One thing. This is a fabulous question, and it's becoming more and more common because schools are being mandated to have therapists in there or are just doing it for a good safety thing. Now, I want to say something. I think school social workers are a fabulous asset to a school.
Definitely.
Dr. Andy Klein, though, pointed something out that was so fabulous years ago when I interviewed her. She said to me, she says, you know, there's a difference between when a school hires a therapist to work for them. Then that therapist, she said, when she was a school psychologist and she was hired by the school to be working in, I think it was a public school or something of that sort, she was in charge of going in to work with the teacher about this client,
right,
going to work with the student and stuff like that. She said what has happened is the model that has changed is an agency hires a therapist. Client A is part of agency A, and therefore this therapist comes into school, really doesn't give two hoots about what's going on in the school, only cares about client A. She is not a consultant to the teacher. She doesn't have any obligation to give the teacher the time to figure out how to deal with this child or anything of that sort. And so she's operating sometimes in a vacuum, dealing only with...
So let me interject, because let me explain what that is, okay? So the question becomes, so first of all, I think as somebody who supervises a lot of school mental health people, I think school mental health can be fantastic for school-related issues. There's two issues going on here, okay? What Hindi was talking to you about goes back to the question of who is the client. If you are a school social worker employed by the school, and I want to actually clarify, because I said this last week about someone who had come to me and said, like, you know, my daughter's friend's therapy is being paid for by the school and my therapy I have to pay for privately. Why? I just want to clarify, because someone DM'd me. I didn't confirm or deny seeing her daughter's friend, by the way. I would never do that because everyone has confidentiality rights. What I said was, in a case where the school is paying me to do therapy, my client is the school, which means the child does not have confidentiality rights, right? Because the school's paying, so they have confidentiality rights, so to speak. I can tell the school whatever I want, and the child has to know that in advance because the client is not the child. The client is the school. Now there is something else called school-based mental health. School-based mental health comes from a model where you put a community health clinic in a school, and that might even be a bigger health clinic where you give throat cultures and you give shots, right? And then you might also have the mental health people working there. That is a clinic model, meaning you're seeing that social worker. That social worker is not internal to the school. The client is that individual child. In that situation, sometimes it's okay to work on a problem that isn't school related, but I have two problems with that situation. First of all, that whole model was built for kind of crisis work and supportive psychotherapy. It wasn't really built for intensive, in-depth psychotherapy about something like a panic attack, right? It's really more for, short-term stuff, or for supportive stuff, or having a safe place to go and talk about feelings, but not really treatment, right? That's what that whole community mental health, community, models are about. Sometimes the problem with that is sometimes you have a kid and the one place she has like an isolated island of competence, one place where things are great, and that's school. If I start pulling her out of like third period science to do her OCD exposures in school, then school becomes another arena where OCD becomes relevant. And that's kind of not fair to the child. And then she has to go through the rest of her day, because usually what happens is the bell rings, okay, the session's over, you go right into algebra. She has no time to process what just happened, decompress, not be around people, right? The world is sometimes too people-y. And like, she just went through a major exposure for OCD. She needs decompression time. The school can't let her have the decompression time because of liability concerns. She can't just wander the hall for an hour. She can't explain to the principal, especially if she's like a fourth grader, that I need an hour to decompress after therapy, because she's going to look manipulative. Or the principals will be like, okay, but we don't do that here, right? It may not be functional for that. Now, can the school counselor be an amazing resource? If I'm treating someone for panic attacks and the panic attacks occur in school, am I going to collaborate with that school counselor to give the kid a safe space to go when she's having a panic attack, to have a toolbox with her, to have another trusted adult as a resource to talk to about her panic attacks? 155%, right? I want that school counselor on board, and we are going to collaborate closely. But the school counselor is not going to be the primary therapist for treating this, because this is not a primary school-based issue. If a kid is bullying classmates, that might be a primarily school-based issue. That might be great for the school counselor to deal with. If a kid is very reactive, and whenever a teacher talks about anything that's squeamish, she feels like she's going to faint, that might be appropriate for a school-based counselor to help her teacher deal with. But if a child is processing like the loss of her father, school-based counseling is not the place for that. Right? Because school is a place to be a kid.
I do want to say that I have brought it up as an ethical issue when a therapist, the fact that a school that may not know therapeutic
boundaries, right,
can suggest to a parent, this I find acceptable. The fact that a clinician can take a case on that they know is of this nature, I find to be very, very problematic, and I have brought this to the attention of several people in terms of ethical issues with the fact that I have watched trauma work happening in some schools.
Yeah, like EMDR should not be happening in the school. Like I can't think of a time that's useful.
This was processing trauma, and like you said, going into algebra after that, and it was no wonder that shortly thereafter there was a question whether the child should be prescribed medication for anxiety, which I have no problem with, except that the anxiety was being completely induced by the form in which the therapy was being done. So I think we have to be very careful, and I think this mother is asking an excellent question. I think that anything that is not, like you said, a directly impacted school-related issue, or, like you said, a supportive form, please, let's keep it out of school.
And that's different, by the way, sometimes the school has access to funding for private psychotherapy that they can then provide a child outside of school. That's a different contract. It's a whole different conversation. It still has ethical things that have to be addressed, but that's separate. We're talking about something else now.
Right. Okay. One more. I'm not sure that we're going to get to too many more, because I think we have about 5 minutes left, but let's try. I went to therapy before I got married. Another excellent question. To deal with trauma. And then both my therapist and I felt I was healthy enough to date and get married. I'm now married for 8 months. I feel like I'm unraveling and need therapy again. What does that mean? That I'm not healthy? My therapist was not good? I liked her. Should I go back to her or try someone else?
Okay, so I would probably say that marriage is a big stressor. It's a new situation. All sorts of stuff comes up when we get married, whether we've been through trauma or not, right? It's a big adjustment to marriage. That you feel like you're unraveling 8 months into your marriage doesn't mean that you weren't ready to get married. Doesn't mean that you're not ready to get married. Doesn't mean that you and your therapist made a mistake. It just means that the first year of marriage is hard. And the first year of marriage is hard when we've gone through trauma, especially, right? So if that's the situation, yeah, so go back into therapy. So you go back into therapy with that therapist or someone else. It depends on a whole bunch of factors. Is there any automatic reason not to go back into therapy with that therapist? I don't hear it. Like, to me, other than having the conversation with her about, like, maybe you've lost a little trust in her and you want to ask her about it, you should have that conversation with her. But I don't think that you and your therapist were wrong. I think you were both ready to be married, and marriage is hard. I think both of those things, in general, we therapists love the word "and," right? Both of those things are simultaneously true. Unraveling 8 months into a marriage, if you've been through, like, a lot of trauma, like you said at the question, makes a lot of sense. Really does from a dynamic perspective. I can understand. I can think of 30 reasons why that would happen. Great. So now go back into therapy and do the work of therapy and of adjusting to marriage. I think that's you're exactly where you should be. That makes sense.
I think I just want to add one thing. If somebody has an awareness and knows the tools that they need to go back into, it usually is not the same form of therapy as it was the first time around, because they're going back and they sometimes need to be reminded of, like, the skills and the growth that they've had, and they're not going back to the same starting point. Almost never, if you've done
almost never. And it's so much fun, by the way, as a therapist. It's such a good feeling, and it's so hopeful for other patients when someone comes back into therapy and their issue was here and now their issue is up here, and it's like, can we stop for a minute and celebrate that this is what you're worried about now, like, and that you've done all of these other things? Like, can we just stop and acknowledge that this is so amazing and so wonderful and like, wow, right? Like, because that's huge.
We have, like, literally 2 more minutes. Let's try this one. My husband struggles with anxiety and mood swings. He won't go to therapy. He says it's not as bad as I make it. I spoke to a friend who is a therapist. She suggested I go to therapy to learn how to deal with it. How can therapy help me if he won't change and he's the one with the problem?
Wow, huge question. Therapy can help you with your emotions around it, and it can help you set boundaries and you understand what's your problem, what's the stuff that you can deal with, and what's the stuff that's totally him. That can be so helpful. And sometimes then the spouse says, oh, wow, she's gaining so much from therapy, maybe I should try it. Sometimes you decide, you know what, his problems are his problems. I'm not going to enable him anymore. Like, there are things I'm just not going to do for him anymore, right? And that's super helpful and super useful. But the idea is you're going through a tough time called having a spouse who has a problem, right? If you're going through that tough time, then okay, then you need somebody to support you through that tough time and help you figure out that tough time. You wouldn't say this, by the way, if it was your kid, right? If your child had a traumatic brain injury and it was so difficult to deal with and you were like unraveling a little bit about dealing with it, and someone says to you, maybe you should be in your own therapy, you wouldn't say, why? My child has the problem. I have the problem that my child has the problem, right? It's the same thing here. So yeah, therapy can be hugely helpful to you in deciding how to handle this problem.
Okay, amazing. Going to take one more that I think may be a quick one, as long as it's not disconnecting us. Let's try. What is recommended for an 11-year-old? Play therapy versus regular therapy?
It's impossible to answer that question because I don't know what's going on with the 11-year-old. Are there 11-year-olds where play therapy is useful for? Sure. Are there 11-year-olds where play therapy is ridiculous for? Sure. It really depends on the issue, and it depends on sort of knowing the kid and knowing what stance of therapy is going to work well with them. I think people know this about me already, that like, I'll always apologize. I happen to see a lot of adults. I identified as a child therapist. I happen to right now be treating more young adults than children, which is a funny thing for me, but I will always tell people and apologize in advance. I talk to everyone like they're 4 years old in certain ways. Like my mashal is like a 4-year-old. Like if I can't explain it to a 4-year-old, I can't explain it to anyone. So I'm going to say it like when I teach someone how to do deep breathing, I call it ABC breathing, right? We breathe in for the count of 4, A, B, C, D. We hold our breath, E, F, G, H, and then we blow out and see what letter of the ABC we could get to, right? That's how I teach breathing. If you're 35, if you're 5, that's how I'm going to teach you how to breathe because that's how I think. So sometimes it's it's not the age, it's the stance of the therapist, right? And how the therapist is going to work with that child. And if the therapist is going to be able to adjust to that child, a very dignified 11-year-old might not like my more babyish stance, right? And I might have to say, look, I'm only doing this not because you're 11, because if you were like 111, I would do the same thing. I'm doing this because this is the best way to explain this, right? There are some issues that are more amenable to play therapy. There are some issues that are more amenable to cognitive behavioral therapy. It's about the clinical issue and the match between the kid and the therapist, not the modality and the age. Personally, just because I'm seeing a 4-year-old doesn't mean I'm going to be doing play therapy with her, right? It's just not necessarily. So it's not about the age, right? It's about what the therapist is doing with the issue and what the kid is presenting with.